Today's CME is focused entirely on the practical management of newly diagnosed HIV patients. Now I would like to move on to my primary duty, formally welcoming all of you. President IADVL Kerala, Dr. David Pudukkadan, is putting tremendous effort in coordinating various programs under IADVL. I welcome Dr. David to the program.
Thank you.
Today's speaker, Dr. Ajithkumar, is a brilliant clinician, teacher, and also an expert in the field of HIV control. I welcome you, sir, to this program. Dr. Yamini Thankachy is a sincere and dedicated officer in the post of Deputy Director KSACS. I still remember her helping me a lot during my tenure as chairperson IMA HIV AIDS cell in 2021. I welcome you, madam.
Thank you, ma'am.
I welcome very active IADVL Secretary Dr. Jovan, ever enthusiastic convener Dr. Deepa, all the members of Executive Committee and Community Dermatology who are actively conducting awareness programs, and I welcome all of you who are attending CME on Zoom. Now I invite Dr. David for the presidential address.
Good evening, dear colleagues. As President of IADVL Kerala, I warmly welcome you to the HIV/AIDS CME and Masterclass, the first CME of our tenure. My sincere thanks to all of you for your active participation in the World AIDS Day activities across the state. I'd especially like to acknowledge KSACS for their wholehearted collaboration and support. A special word of gratitude to Dr. Yamini Thankachy, Deputy Director KSACS, who was instrumental in making this program possible and ensuring wider participation from medical officers and field teams. I appreciate our Community Dermatology Committee and Media Cell for taking up this initiative at short notice and efficiently preparing the banners, flyers, and promotional materials for HIV Day. Today's session focuses on delivering practical, clinician-friendly guidance for the evaluation and evaluation and management of HIV, a knowledge that remains vital in everyday practice. We are having Dr. Deepa, who is the convener of Community Dermatology, leading the Q&A session. And we are honored to have Dr. Ajithkumar, Professor and Head Dermatology, Medical College, Kottayam, giving us his insights during this masterclass. Thank you all once again for joining. I encourage you to participate actively as we begin our tenure with learning, collaboration, and purpose. Thanking you. I'll ask Dr. Yamini to say a few words.
Good evening to all the office bearers of IADVL and all the participants who have joined here. Everybody has been listening about HIV. We were just talking about it. As December 1st comes, everybody starts talking about it. And then maybe after maybe after 2 or 3 weeks, then it is forgotten until the next December 1st. So anyway, the main thing is that one, IADVL has been in constant collaboration with Kerala State AIDS Control Society for various activities, be it screening of the sexually transmitted infections, or be it the treatment or outreach programs. We have been collaborating with each other and thinking of ways in which how can we reduce this menace which is coming up. Unfortunately, we are having a slight increase in the prevalence, both in our surveillance, which came through. Our prevalence has increased from 0.06 to 0.07. As well as there's been an alarming increase, as all you IADVL members who are dermatologists know, that there has been an alarming increase in the number of STIs that we have been seeing. So if there is, and this has been happening for the past maybe 2 or 3 years. So if there is an increase in the STIs, which is happening in Kerala, that means HIV is not far behind. because it has the same route of transmission. HIV is also slowly increasing. And unfortunately, when we look at the data, we are finding that we are getting a lot of young population now infected with HIV among the 15 to 24-year-olds. We were just analyzing the age group, and the youngest person whom we got as positive was 16-year-old. And we also know that the changing dynamics of the society also we have been seeing lately, how multiple partners or early premarital sexual activity is all very common, and it does not have a taboo anymore, which was there during our generation. It is no longer there. So there is more of risk activity among our population also, and that means we are all at risk of having much more infections, not only in the sexually transmitted diseases but also in HIV. So it is very, very important that we sensitize all the population, not only our youngsters, but also the adults, the ladies, the children, the school children also need to know about it, because the drug menace is also somehow affecting our HIV infections and the increase in the rate of HIV infections. So it is a very good initiative, and Kerala State AIDS Control Society is very happy to collaborate with IADVL again in this webinar, where we are trying to sensitize not only the people in our government setup, not only the medical personnel, all levels of medical personnel need to be knowing about HIV. Not only them, but we also need to rope in the private sector, because a lot of in Kerala, our people are going to the private sector, and equal sensitization and equal response to HIV from the private sector will also always help us in tackling this situation that we are going through. So I wish that the webinar will be very, very useful to you, especially since it is Ajit sir. It is going to be very, very interesting and knowledgeable to all of you. And I hope it doesn't end over here, and all of us can work together throughout the year forward in combating this HIV, AIDS, and sexually transmitted infections. Thank you.
Thank you, madam. Then we have gone to Deepa.
Yeah, Joan ma'am. Joan ma'am has
ma'am. Start. You can start, ma'am.
Yeah, ma'am. Okay, ma'am. So my role here is I'm the convener of community dermatology at present. My role here is just to extract the abstract from a great HIV expert our nation is proud of. That's none other than our Ajithkumar sir, Professor HOD of Government Medical College, Kottayam. And he's got a lot of credits on his side. One I would like to make mention is he was a pioneer in making a model of HIV care in Thrissur way back. And from there, he got a national acclaim. And from the parliament, he got a appreciation. And they replied to him like, this is really a role model of HIV care. And that paved the way for the National Control Program. And that paved the way again for the National ART Program. And his contribution is immense and tremendous. So over to you, Ajithkumar sir. Words don't suffice to tell about you. So let's start off with what we would all like to know. I'm talking in terms with the private practitioners and the general practitioners and the dermatologists at a level where we don't have an institutional support. So this webinar is going to benefit everyone with all the practical tips. So Ajit sir, what is the present HIV trend which we are seeing now? Is it declining or is it?
Sir, unmute sir. Unmute. ചെയ്യണം.
Okay. I hope I'm audible now.
Yes, sir.
Okay.
Very much.
Dr. Yamini has already answered that question in her introductory speech. This is what I could gather. All India level, initially there was some decline. And after that, it's probably status quo or there's a slight increase. In Kerala, we continue to have somewhere around 1,200 new cases every year for last maybe 10 years. So we are nowhere in control of the epidemic. We are almost the status quo. And definitely the disease in individuals are under control. The virus is under control. So they are surviving longer. So definitely the prevalence will go up. So that we have more individuals with HIV infection in the community. And the moment they stop ART, they will continue to have virus them also in circulation. So, actually, we thought in the last few years that HIV is no more an issue, but that's not true. It continues to be a problem, though we know how to manage the disease.
So why is it so, sir? Well, actually, with the advent of ART, with the transmission to mother to child transmission coming so low as till nearing zero, why this rise in HIV cases? Can you explain something in regard to this?
Exactly, we don't know why it is there, but that is the scenario world over, probably. One reason probably it's all presumptions. One reason probably is last few years we completely switched to a medical model. We thought ART will solve all the problems. With PrEP, PEP, and ART, we can solve all the problems. See what's happening here. So around 1,000 people we are detecting. That means there's another maybe many patients who are not detected. Their virus is not under control. So unless we go back to our behavior model and psychosocial model, we will not be able to address the patients who are at risk and those who are still carrying the virus. And see what is happening in the STI, like rightly mentioned by Dr. Yamini. We are seeing more and more syphilis cases, new syphilis cases. So that means there are sexually transmitted infections and ulcerative STIs and urethral discharge STIs are increasing. So that means all these STIs will increase the chance of transmission. So in effect, due to some reasons, mostly it is social or economic or combined reasons, there are more people at risk now. Again, what Dr. Yamini mentioned reflects younger people are getting affected. So we should address that. So that cannot be addressed by drug. That can be addressed only by addressing the people at large, the social issues associated with that.
So what is the initiative we must be taking, sir, as doctors in this group?
Oh, that means actually we should reassess the situation. We may have to. There was a time when the whole system worked against HIV.
Yes.
Politicians, financing, the health and social supports, everything worked against it. There was a fight against HIV was not isolated. Now, in the last few years, probably it has, so unfortunately, probably got focused only to ART and treatment only model. So probably we will have to go back.
Even the reporting, even HIV people, maybe the stigma is coming down, sir. People are coming and reporting themselves.
Yes, stigma has come down significantly, but I don't think stigma has gone completely. But no disease you cannot remove. Anybody who has a disease will have some stigma attached to. Even if I get a bad sore throat, or if I start coughing now,
Yeah.
I will get some stigma against me. So that will be there with all, but it's significantly less than what it used to be.
Fine. Yes, sir. So suppose we get a patient, we are actually speaking in terms of a general practitioner, how they can give their best service to HIV positive patients. Usually we get a patient coming with a report of HIV positive from a local lab. So how do we go about this case, sir? What should we do next?
Once they come with a result of HIV positivity from a local lab, make sure that whether the result is genuine itself, and make sure that he gets proper counseling. Either you can give a pre-test counseling, even though actually it's not a pre-test counseling. You should really start a pre-test counseling and tell them about what is HIV. In the current scenario, it's a treatable disease. So, but this single test is not good enough. Should get tested from a lab which is accredited, either ideally an ICTC from one of the government centers, or centers which as good as ICTC. And you should get 3 ELISA tests done. That's what the practical thing we can do now. And also he should get evaluated for any existing OIs, opportunistic infections. And if you want to get to treat him, you can very well treat him, no problem. Otherwise, ideally is to refer him and link him to an ART center, nearby ART center. Almost every district has at least one ART center now. All the places where there are medical colleges, there are more than one. All district hospitals has ART, and all medical colleges has ART center. And many taluks and hospitals have link ART centers also now. So it's not very difficult to reach a place where they can get care. And if they go to ICTC, they themselves will do that linkage. So it's not difficult now.
So how do we assess the risk of this patient who's come with the report, like who come under the high risk groups? Can you categorize them?
No, I don't think we should categorize them, but we should find out what's the risk they have, whether they are having multiple sex partners, or whether he had an unprotected risky exposure, whether he had IV drug use, or whether he had, if at all, sexual exposure, what kind of sexual exposure it was, whether it's an MSM, bisexual, or whatever. And that is not to stigmatize him, but that will help us to say whether this infection single test is likely to be positive or not. If he convincingly say that he never had any exposure or risk, probably we can think that this test is likely to be a false positive test, which is rare. That's all. Otherwise, the need to do this risk assessment is to see whether he continues to stand the risk and get other STIs also. That's all.
So, in case he is a commercial sex worker having a man having sex with men, or a truck driver, there'll be a higher risk in these.
Yeah, definitely they have a higher risk because exposure will be more traumatic, or maybe the frequency will be more. It's unlikely that many of them using condom consistently.
Yes,
So because of that, they are at risk.
So how should we suspect HIV in a patient? So on clinical examination, what are the findings that you must look for?
Okay, it's a clinical examination. When you suspect, one is loss of. Initially, we used to look for all the so-called AIDS-defining diseases like loss of weight, disseminated tuberculosis, extrapulmonary tuberculosis, uroesophageal candidiasis, evidence suggestive of some features suggestive of PCP pneumonia, like dyspnea on walking, diarrhea, chronic diarrhea, severe seborrheic dermatitis, multidermatomal herpes zoster, so any number of. So practically, you should do a head-to-toe examination and look for anything suggestive of an immunosuppression. If anything suggestive of immunosuppression, along with other immunosuppression, should think of HIV also. But remember, many of these conditions can happen in an uncontrolled diabetic also, like oroesophageal candidiasis. Okay.
Yes, sir. So can you tell us something about the counseling part? What all should be included in the pre-test counseling as well as the post-test counseling?
Yeah, pre-test counseling, you tell him that how much risk he stands. Discuss and find out, or let him find out, himself understand how much risk he stands, and he can decide whether he really wants to get tested. And so we'll tell him that what the advantage of getting testing, and after, if he get tested positive, what all things he should expect and do. If he is negative, what all things he should do. Because maybe he is having a risk, he doesn't have infection now. Probably he has a VDRL reactivity now. Okay,
Yes.
so discuss all those issues with his risk, what are the possibilities, and what are the things he should address, and let him make a decision. So if he decide to get tested, help him to get tested. Then he comes back with the result. Maybe it's positive or negative. Then tell him the implications of positive test, and he should be started on ART, and how ART can keep his life almost normal, and implications. We can help him to disclose if he want to disclose it to the partner. Then other STIs, the need for testing other STIs, getting linked with ART centers, getting a treatment, regular treatment. All those things we can explain to him. And again, counseling is not an event. It's a process. So he may have to come many times, as much times as he wants. And we will continue it as a treatment counseling.
So by the way, what's your experience in breaking this news to this patient, sir? Like he is HIV positive. How do you break the news, sir?
That depends on...
It's an art,
the initial days when we started practice in 2002, 2000, or even before that, disclosing the news was almost like a death sentence, because what we are saying that there is no treatment. That's in very initial days. But actually we changed from that a lot. Even then there was hope. Okay, somebody with CD4 200, I used to tell them that if you take PCP pneumonia, definitely for 2 years nothing will happen, because the CD4 falls by 50. If you prevent PCP pneumonia, at least for till the CD4 reaches 100, he will not get any deadly disease. So we used to tell him that, okay, this is a disease which slowly progresses, you can plan your life. And by the time there are medicines in other countries, you may reach here. That's what exactly happened. Okay, now all those days are over. What I used to tell them that, okay, you should be on medicines. There are medicines which can control the disease, and you can have almost a near normal life. And probably this disease is better than a bad diabetes, because you need to take only one tablet. A bad diabetes patients may need to get to insulin 3 times a day or 2 times. Okay, but he may have to change his lifestyle little bit and prepare himself for that.
So at times the patient may deny ART, sir. In such situations, what are the points you would like to push for the patient to?
I never push ART. I tell them that, okay, this is a disease which can be controlled. It's up to you whether to start or not. Okay, if you start ART early, your health will be preserved better. Okay, yeah, but every time he comes, but I will never deny my support to him just because he didn't take ART. It's up to him. There are many patients who delayed it for years and years. And there are some long-term survivors without ART. Nothing happened to them. They are still not on ART. So we don't have control of all those things. So let them decide. It's their decision. But our role is to be supportive and counsel them, give them information, help them to make their own decision.
What is their life expectancy? So with ART and without ART, are there any studies?
Without ART, probably 8 to 10 years on an average, but there are long-term survivors. There are fast progressors also. In 1 or 2, I have seen patients dying in 1 or 2 years. There are patients who are still surviving for 20, 25 years without ART also. But on an average, in India, around 10 years, 12 years is the life expectancy. With ART, it's almost normal life.
Yes.
You can't say how long we will live.
Okay, sir.
Okay.
So now regarding the confidentiality, some patients insist that this result should not be revealed to anyone else. They insist and in fact the demand.
As a doctor, we take the oath not to disclose any information about any patients to anybody unless that person wants. So that applies to HIV also. It's not only HIV, hemoglobin also we are not supposed to reveal to anybody else if the patient doesn't want or without patient's consent. So
But
there
in
is
case-
no exceptionalism for HIV.
Okay, sir.
The only thing is we don't take it seriously, but we should take it seriously.
No, if our intention is like if the wife is negative or if the partner is negative.
Partner is a different issue. Now there's a HIV Act which clearly says that you can talk to or tell the partner, provided the partner comes to you. Now, we don't go searching for the partner. If the partner also comes to you, you can tell the partner, provided there are 3 conditions. One, you counsel the patient and tell the patient the necessity for counseling or disclosing it to the spouse. 1. 2, there's a real risk of transmission. For like partner is in America, he is living here, she's not planning to come back, no need to disclose it.
Yes.
So there's a real risk of she or he getting in it. Third, you are sure that he will not disclose, and you should tell the patient that you are going to disclose. So if you can satisfy all these conditions, you can tell the patient. Other situations where you can disclose HIV status is if court of law says you should disclose due to some legal reasons, then you can disclose. Otherwise, you cannot disclose. But there's one more tricky thing in the Act. You need not disclose to the male partner about the status of female partner, but only to female partner about this status of male partner, because there's a chance of violence.
Again, women empowerment.
Sorry to interrupt you, madam. The slides are remaining the same. Slides.
Hello?
Not changing the slides. That's what.
Okay.
No, we are not changing because we are just going.
No, there are only few slides. That's why.
Very few slides are there. We're not
Okay.
going with slides. We are going with sir's interactive speech.
Okay.
Thank you, ma'am. So again, what are the baseline investigations you will call for in a patient with HIV positive? And why do you want all these tests?
There are no mandatory tests to start ART now. Most important thing is to start ART. But there are a few tests which are suggested, but good to do, like counts, LFT, RFT, because tenofovir can cause renal failure. Dolutegravir rarely can cause hepatitis. Definitely, blood sugar cause 30% of our population is diabetic, so glucose, any chance of getting tested, you should use. PDRL, hepatitis B, hepatitis C being sexually transmitted disease, yes. CD4 will tell you where this patient is on. So that will help you. which is available in almost every ART centers now. Chest X-ray to rule out tuberculosis. Pregnancy test is very, very important because if patient is pregnant, should especially be careful to make sure that patient takes ART regularly and to prevent the mother to child transmission. These are the tests generally advised. Then you can do bigger tests like viral load and things like that, resistance. But that is not in NACO guidelines as a mandatory thing to start ART. Western countries do even genotyping and detect and decide the resistance before starting ART. But we don't do that.
So when do we start ART, and is it mandatory for all the patients?
It is zero ART now. Start on the day of ART, of detection, if possible. So I would say that whenever the patient is ready, but getting him ready is our duty. I used to tell the patient that it's like getting married. When you are ready, but get ready when you are prepared for that. Okay, if you really want to do that, then get ready fast and continue.
So what are the steps in the linkage of these patients to and get them
Our
registered?
patients usually go to ART clinic, especially in Kerala. There are only few private practitioners provided, private hospitals. There are few. So usually they go to ART center run by the government. They get registered there. We give all the details. They have to give their identity, etc. But they are kept confidential. Then they go through the counseling. Then ARTs, the basic investigations are done. ART started, and this database is kept there, and initially every month and then every 3 months they are supposed to come to ART center to collect the medicines. Every time when they come, their weight is measured. Any evidence of tuberculosis is looked for, like cough, loss of weight, lymphadenopathy, etc., looked for. And if necessary, other investigations are done. Also, all the patients are started on TB prophylaxis if they already doesn't have a tuberculosis for 6 months, INH prophylaxis. And those who have a CD4 less than 350, cotrimoxazole prophylaxis against against PCP pneumonia also started. That is continued till the CD4 becomes 350. They're also linked with the nearby care and support center, which is usually run by a group of HIV positive individuals. They give various social and psychosocial support for them.
Sir, how does a general practitioner in his own clinic, if he gets this patient, what should he be doing? Like in the government sector, it's quite easy. There's a proper channel and system. And in the private sector,
if he really is not a trained HIV physician or somebody who knows how to manage, he can easily refer the patient to ART center. Referring means he need not lose the patient. He can still continue to give general care. If he gets a fever, he can still treat the patient. If he gets tuberculosis, he can treat the patient and refer back to ART center. And if he wants to start ART, it is available outside in the market. Tenofovir, lamivudine and dolutegravir will be available for something around 1,000 rupees or 1,000 plus. There are many doctors who prescribe it also. But make sure that patient is taking regular medication without breaking. It's a very unforgiving medicine. If they miss 5% of ART, the chance of failing is around 80%. So we should make sure that it's not just giving a prescription. We should make sure that patient takes it. But it is available. It can be given from that.
So, Regarding the what are the common opportunistic infections you find in these patients?
I would say the most common will be candidiasis, which all of us manage. Can be
How
oral
do you treat them
candidiasis or
also?
something. But the most important one will be a pulmonary tuberculosis or extrapulmonary tuberculosis. So it can present with various manifestations. It not be typical fibrocavitary tuberculosis. It can even present as a pneumonia. It can present as loss of weight. It can present as lymphadenopathy. I used to say every organ except hair and nail can get tuberculosis. I've seen pancreas and the kidney, I've seen almost every organ with tuberculosis. That's one of the commonest. Pneumocystis jirovecii or pneumocystic cardiac pneumonia is very common, used to be very common. Now we don't see many. They present with subacute pneumonia. They present with mild fever, dry cough, exertional dyspnea, severe hypoxia on exertion. And this can be easily treated with cotrimoxazole and steroid. Cryptococcal meningitis, again, chronic meningitis-like presentation. They present with headache, vomiting. It may not be as florid as a bacterial meningitis. May have to suspect it really to get not to miss it. Then that should be treated with probably confirming it by an LP and various antifungal agents. Candidiasis we already discussed. If it's esophageal candidiasis, 3 weeks of fluconazole. Cytomegalovirus need expertise to make a diagnosis, but usually they present with visual dose or visual dose. Toxoplasmosis usually presents with hemiparesis or hemiplegia. That also can be treated easily actually with cotrimoxazole. Bacterial infections, various bacterial infections also we see, but we don't see any of these in the recent years. Very rarely we see these in the recent years, but we do see occasionally, which should not have happened. Still, we get patients with advanced disease. We should now have such patients if we are detecting all of them early. Okay.
Are there prophylactic drugs for these opportunistic?
Yes, anybody who has CD4 less than 350 should be on cotrimoxazole prophylaxis. Just cotrimoxazole tablet, double strength, 1 tablet a day. That will prevent PCP pneumonia, that will prevent bacterial pneumonia, that will prevent bacterial infections, diarrhea, toxoplasma. So that's a wonder drug, very cheap wonder drug. Then those who had cryptococcal meningitis with a low CD4 should be on fluconazole prophylaxis. TB prophylaxis for 6 months is norm now for those who doesn't have an active tuberculosis. These are the prophylaxis which usually we offer.
Sir, now the tuberculosis preventive therapy is with rifampicin only for 28 days.
Okay, okay. So thank you, madam. It's changed. Okay. So it may have become much more simpler, and induced problems also not there now. Okay.
Yes, sir. So it is easier. Just 1 month.
Just 1 month. Thank you.
So after giving the patient ART, how frequently you call back the patient for review, and what are the tests we do in the
initially every month? That is a guideline, but I used to I would wish to see them more frequent, because initial days they can develop problems of the drug. The new combination is actually very patient friendly, but still, then to make sure that they don't have misconceptions and issues like that, they are taking it regularly, they feel that they are cared for. A lot of non-medical reasons also, I prefer them to come every 2 weeks or something like that, at least once a month. Then also make sure that there are no drug-induced side effects and no iris. Many a times when you start ART, if they have an undetected infection, that will become more obvious because of the immune response. That is called iris, immune reconstitution inflammatory syndrome. that can happen in the first 1 or 2 months. So because of that, I would like to see it frequently. But after that, every 3 months. Now ART is given every 3 months. So they can come and collect it. But whenever they have a problem, they can come. And they do viral load 6 months. Mostly the viral load will be target not detected. That is zero, near zero. There is nothing called zero, but near zero. And CD4 is done whenever indicated. Then we don't do, then viral load is done at 1 year. Is there any change, Dr. Yamini, now? So 1 year?
Newly initiated first viral load at 6 months. After that, annually.
Annually.
That's
And when the video viral load decreases, then we'll go for CD4 and think of changing the regime if necessary. But
Yeah,
if
most of
patients
the
are
time
regular,
viral loads are there is when there is unsuppressed viral load, most of the time it is due to adherence. So we are supposed to give enhanced adherence counseling and
that's
repeat
what
the viral load.
Yeah, I was about to tell that. Actually, when the virus is coming back, that means patient is not adherent. It's almost 100%. Sure. You may have to need detailed counseling and find out why they are not taking the medicines and reinforce. Most of the time with reinforced counseling and regular ART gets controlled. If not, probably there's a resistance, which is very rare. In that case, we may think about changing to a second line if you are sure that patient will take the medicine regularly. Otherwise, no point.
Yes. So we are moving on to another scenario, so like a patient coming with HIV positive man having his wife pregnant. She is also HIV positive. They're coming to us asking for MTP. We don't want the child with positive, HIV positive. So how do we make them understand the situation and what advice we would give?
I'll talk to them and tell them that as of now, HIV is not an indication for abortion. If they can decide whether they want to continue pregnancy, it's a different issue. But not just because of the ART, because the transmission is almost zero. There's no zero, maybe definitely less than 5%. We don't have many HIV infected children in Kerala now since 2010. 2010 actually we had a zero HIV transmission, mother to child transmission, as long as back as 2010. Yeah, after that also we may see 1 or 2 patients once in a year. So that is it's a very eminently preventable infection, mother to child transmission. We give the same regime. Anyway, patient has to be on ART lifelong, and then we give the same regime. Okay. And that is effective. Now, actually, cesarean section is not advocated because viral load will be negative by the time of delivery. They can breastfeed, and the child is given nevirapine for 6 weeks, and very rarely they are infected. The children are infected. If they have already exposed to nevirapine, instead of nevirapine, pseudovidin syrup is. So
should it be
complications anyway, ART clinic will manage.
Should it be continued in the infancy, or when do we stop ART for the child?
They test delivery at 6 weeks, 6 months, 1 year, 2 year, actually 18 months. 18 months we do a antibody test, and that is negative means it's negative.
Okay, so we can stop with that. Is it that treatment can be stopped? Okay.
Actually, one more thing I just wanted to add, that is if the mother is still breastfeeding the child and she says that I want to breastfeed the child till he's 2 or more than 18 months. If that is so, we allow the mother to breastfeed, stop the breastfeed by 2, wait for 3 more months after the breastfeeding has stopped, and then do the final test.
Yeah. That is there, but generally they need not actually continue beyond 2 years. But okay, if they decide to do that, okay. After stopping breastfeeding, you'll have to wait and then only do the testing. And because there can be transmitted antibodies with the patient.
Yes, sir. So that's clear. The other very important field to be covered is, as Yamini Madam told, it's the same route of infection, HIV and other sexually transmitted infections. So we have a program also on that. So what are the common STIs we see in our daily practice?
Till recently, we used to see common viral infections like anogenital wart and herpes. That was the commoner ones we used to see. But in the last 2-3 years, we are seeing more and more syphilis. Even our center, we see at least 1 or 2 syphilis at least a week. And gonorrhea has also increased. Probably last 10 years, we are not seeing any gonorrhea. Now last week, we saw 2 gonococcal epidermal cases. So these are 2 bacterial STDs coming back. There are few cases of chancroid reported from other centers. We had a suspected case. And also donovanosis, which we thought is eradicated. There are some reports from the north now. So most of the bacterial STDs are probably coming back. So we should be a little careful.
Right. What about the ulcerative STIs and their relation to risk of HIV? Getting a
definitely any ulcers in the genitalia will increase the chance of transmission. Both giving and taking, both will be the chance to have.
So in our general practice, we get patients coming with only a report of VDRL positive, report with no other symptoms or signs. So how do we
first thing again, take history and ask for the risk, whether there's a risk. If there's absolutely no risk, again, then it may be a false positive VDRL also, which can be seen in many conditions like SLE, leprosy, malaria, various diseases. Even pregnancy can induce a false positive VDRL. Do a TPHA, a specific test. If TPHA also is positive, that it's syphilis. Then do a titer of when you do VDRL, always should do in a titer. If the titer is more than 8 dilution, that means it is a recent infection. It's not generalizing it, but for practical purposes, it's a recent infection. So, but if it is less than 1 in 8, it can be an old infection, treated infection, partially treated infection also. So, if anything more than 1 in 8 and history of exposure recent, you should treat with benzethine 2.4 megaunits single dose. And if it is the contact is more than 1 year or the titer is low with the TPHA reactive positivity, then you should give 3 injections, weekly 1 injection, 3 doses. Then follow them up. 3 months, 6 months, so guidelines is 6 months. And if the titer is increasing by 4-fold, that means reinfection. It's a reinfection or a relapse. Then you'll have to retreat. Usually slowly decreases and remains as zero dilution, or most of the time it becomes non-reactive. But remember, the TPHA will remain post-reactive lifelong. It's a scar, so you cannot remove that. So, and ideally it is penicillin. You should give penicillin as far as possible for penicillin, because there's no penicillin resistance so far. The national guideline is to give penicillin only, unless even if the patient has a penicillin sensitivity, the recommendation is to desensitize and give penicillin, not to give doxycycline.
So what is the efficacy
with doxycycline is, people may ask why not doxycycline. There's no guarantee that patient will take 14 days of doxycycline, or if it is late, very late syphilis, so 30 days or 28 days of doxycycline. Once they miss it, then it's may not be effective. So we don't know how much effective really is doxycycline, even though it's effective in most of the cases.
Patient may deny once we counsel him about the anaphylactic reactions. He may say, no, I don't want to take. In that case,
no, it's
we
up
have
to
no
the
other
patient.
option.
If patient absolutely says, no, I don't want this thing, penicillin, you can give doxycycline. Tell them
Yes.
that I am not, what I used to tell them, penicillin is almost 100% sure. Doxycycline is not 100% sure.
Yes.
But if you want to take that risk, it's up to you. But we are ready to give penicillin.
So in other situations, a person who is a commercial sex worker, in Ernakulam in our OP days, usually they come and ask us, can you give me some drug so that I can go for sex? They usually use the apps where they don't see the other person, they do unknown status of the other person. Just through digital platforms, they get connected. So they want to have a drug. What
The
is
pre-exposure prophylaxis is actually is recommended now. India has a recent pre-exposure prophylaxis guideline and a document which can be downloaded. Usually we gave tenofovir combination can be continued, but it's not like just a prescription and go and take it. It is usually given for high-risk people after testing negative, because those who are having risk and having an HIV cannot give 2 drugs and leave them off, or even 3 drugs and ask them to take. Then we should be started on this thing. And if they are negative, and if they want to continue the risk, then they can, after all the initial investigations, they can start on tenofovir and get tested frequently to make sure that they are not getting seropositive. And at least every 6 months, we should check and make sure that they are not HIV positive. And also they should get, ideally they should use condom also, because this will prevent only HIV. It will not prevent syphilis or any other STIs. Okay, so they can continue. So we don't have a program to provide this as far as I know, but probably that may be part of our program soon. So
what is this event-driven?
Event-driven is if somebody decides to have a risky exposure on a particular day. He's not having it regularly, but on a particular day he wants to have an exposure. He doesn't have control over that situation. He can take antiretroviral drugs, 2 tablets before the exposure, 1 tablet after the exposure, and one tablet that is 24 hours and 48 hours. This reduces the transmission risk to somewhere around 60 to 70%. It's not 100%. You don't tell them that it is 100%. It's not 100%. It's around maybe, I think, 68% or something.
Long-acting drugs are in the form of injectables. Are they available?
I think this drug started coming to India. I don't know whether it is easily available. Cobetegravir and like that, which can be injected once in 8 months. There is another drug which can be injected once in 6 months. But all those drugs, I don't think it's easily available in India.
What about the HIV positive sexual partner?
HIV
Can
positive
she
sexual
avail of
partner, if
ARV?
that partner is viral load undetectable, pre-exposure prophylaxis is not really necessary. We don't know how much extra advantage is there by the native partner also is also taking the prophylaxis. But if you are not sure whether that person is not virally controlled, pre-exposure prophylaxis can be taken. Or even post-exposure prophylaxis also can be taken after the exposure. That's for 28 days. 3 drugs for 28.
So coming to PEP, you just explained, sir.
Yeah,
What are
the
the
same thing
situations?
can be occupational or non-occupational. Occupational is like people like you and me who gets exposed by needle or
Needle stick injury.
exposure to fluids or something like that. 28 days of tenofovir in dolutegravir. But it applies to sexual exposure also. So it's like somebody who happened to have an exposure and then knew that his person is negative, positive, or somebody in relationship with a positive person, or sexual violence. Such situations, you can use post-exposure prophylaxis. And actually now the Indian guideline says that we should provide it to victims of sexual violence.
As we are coming close to the end of the session, can you please take a few questions, sir, in the chat box if they
Sure.
are there? Joan, ma'am, over to you, ma'am.
Dr. Yamini also can help me.
Yes, shall I ask the questions which are there in the chat box?
Yes.
Yeah, ma'am. Over to you, ma'am. Joan, ma'am.
Dr. Shobana has asked, is it a real number of patients? Because many would be consulting in private sector also. The number projected.
Can you?
We are not able to hear you quite well, ma'am.
Can you be more louder?
Yeah. Am I audible?
Yeah,
Yes.
now you are, ma'am. Now you
are. We have one question from Dr. Shobana. Is it a real number of patients? That is the number which was given. Or is it because the patients are consulting private sector also?
Dr. Yamini will be a better person to answer that because what I said is KSACS data.
We have an estimation done by National AIDS Control Organization as per the prevalence in each state. So our estimate in Kerala is that there should be 24,416 positives in Kerala as per our prevalence. And right now, the people who are on ART and alive in our ART centers are 17,761. So there is a gap of around 6,000, 7,000 people who are either taking, who have already tested and taking treatment from the private sector, who have not tested at all and are postponing even though they know they have risk factors, or who don't even think that what they have, they actually have a risk factor and are not going for screening at all. So these three kind of people are out there among these 7,000 whose data we have not yet got in our KSACS data.
Can I add to that? Personally, I don't think we have 7,000 patients in private sector in Kerala. Because
not private alone, sir. It is also the people who have not yet tested.
Yeah, that's there. Yeah, I agree. There are many who have not tested. That's why it's transmitting.
Yes.
Okay. Thank you, ma'am. Thank you, sir. The next question is from Dr. Preeti. Sir, is there any legal issue in writing patients on ART on the OP ticket? And how do we denote it? Can we write biological hazard on the investigation forms of these patients?
There's a definite legal issue. If somebody files a case, you will be in soup. Okay. Nothing identifiable should be there in the record. On the public document which you give off. Okay. Something which you keep to yourself and not sharing to anybody, or if you're sure that the confidentiality is only shared, you and your nurse only see that, nobody else will see it, probably you can write. But if you are writing it in a prescription, definitely it can lead to a problem. And I think it is how many years of imprisonment and a few thousands of fine.
Yes, up to 1 lakh of rupees and 2 years of imprisonment.
Okay.
if it is found to be true. And also, unfortunately, from medical colleges, I have been given OP tickets in which it has been written in capital letters HIV positive and underlined. The PLHIV came and showed it to me. So it is very unfortunate. So we had a meeting with the medical college and we showed them the OP ticket. So we have that is also one of the reasons why we want the sensitization of all our medical personnel, especially the students, the house surgeons, the PGs. They need to know what is to be written in a OP ticket or a case sheet.
Thank
Yeah,
you.
ma'am. It's
Thank
from the
you.
house surgeon side, actually. They do many things which
Yeah,
we may
unfortunately,
overlook.
what happens in our setup is we don't have separate OP ticket and separate medical records. So the OP ticket doubles as a medical record also. So whatever you write will be in the OP
Correct.
ticket, and the patient will be showing it to every pharmacist and every neighbor and everybody. And ultimately, it can lead to problems. May come in even newspaper tomorrow.
So we
Sir,
have
a
a question.
consensus has to be taken about what has to be written on such case sheets and OP tickets. That is the question that's been asked.
You know,
So,
we have done this exercise many times in the past, but somehow, this gets lapsed again and again. In a medical records, all the data information should be there, but in a prescription, none of them is necessary. Only the medicine details and how to take the medicine is necessary. So what I used to advise my PGs is that in case you have something which you don't want to tell others, give it separate prescription. Give another piece of paper and write all the medicines in that and give it and tell the patient that all this data is written in this, all this, your positivity also is written in this. You keep it secret with you. So that is a medical record and the prescription is separate. Even if it is written Sidodin, Lamivudin in that prescription, that is, you are not liable for that because you can write only the medicines. But if you
Yes.
write HIV positive plus Sidodin, then it's a problem.
Okay. So we have one question from Dr. Meenakshi. CD4 counts set at 350 Septran prophylaxis. So do we have any other cutoffs of CD4 for other prophylaxis?
For quatrimoxal prophylaxis, 350. Actually, that 350 cutoff is kept to make sure that everybody eligible is getting it, and also prevents some diseases which comes between 200 and 350. No other prophylaxis actually is recommended as a primary prophylaxis, except for tuberculosis. Secondary prophylaxis for fluconazole prophylaxis for this cryptococcosis and quatrimoxal prophylaxis for the toxoplasmosis.
Dr. Shibu has asked, if the patient has Septran allergy and with the CD4 count less than 350, what alternative medicine can be given?
Most of the time, Dapsone works. The recommendation is another pentamidine, which is not easily available. Dapsone, that what I used to give is Dapsone, and it works.
The next question has been answered by Yamini madam. So I'm going to the next question. Dr. Rahul has asked if for infant only prophylaxis only with nevirapine or nevirapine and Sidodin.
Only nevirapine.
Okay.
If nevirapine is contraindicated, like mother is already exposed to nevirapine, then Sidodin. Or if it's nevirapine is not available, syrup nevirapine is not available, then Sidodin. But Sidodin is more difficult to get than nevirapine now. Okay.
There's another question from Dr. Preeti. Should we consider the titer of TPHA, which is done from outside labs?
No, it's only positive, negative. That's reactive, non-reactive.
Then
Yes.
Dr. Nafisa has one question. Why do Why do we give Septran to HIV patients? How long should it be given?
Okay, cotrimoxazole or Septran or Bactrim is the drug which can prevent PCP pneumonia, which is one of the killer diseases in HIV. And it also can prevent diarrhea, chronic diarrhea, and also can reduce the chances of bacterial pneumonia and bacterial meningitis. That's why we are giving it. We give till the CD4 reaches 350.
The next question by Dr. Janardhana, I think sir has already answered. Can we give 1 month doxy for VDRL positive without further investigation? Is it as effective as penicillin? Sir has answered it early in his speech itself. Dr. Shobana has come out with another question. Husband HIV positive and wife negative. They want to have a child. What advice should we give?
Advice will be to get the medicine
just
ART
discussed.
regular, make sure that viral load is undetectable and have the child.
The mother is negative. The lady is negative. Sir.
Yeah, the chance of transmission is very, very
less.
low. But they should be counseled and there should be an informed decision, even though very, very tiny risk. Because if the patient didn't take medicine, the husband didn't take medicine for 5 days, there's a risk. Still, there's a risk. So, it should be an informed decision. But if they want to go ahead, then they can. Probably. Actually, this is one of the indications for pre-exposure prophylaxis now in the guideline. Discordant couple want to have child.
Dr. Nafisa is asking, is the same medicines from ART available in private centers also? Is there any difference in medicine?
No, it is the same. It's the same company providing it because it's a very strict quality control for the medicines available in ART center. It's bought by Government of India. It is the same medicine. And actually, this quality control is decided not only by Government of India, it's by WHO also.
Dr. Jasmine has come out with the same doubt. What to write on case sheets and OP tickets about HIV status of a patient? Sir, tried explaining it.
What do you want to write on the case sheet? Inside the case sheet, you can write. What do you write in a patient with SLE? You write any inside the case sheet and some diagnosis as SLE in the book. Like that, you can write HIV inside the book. Also, where do you want to? You can write it on the chart also if you are so insistent, but make sure that it remains confidential. It doesn't go out.
Dr. Nafisa has one more doubt. If the patient is having high creatinine level, what changes should be done in the medicines?
Can you repeat it?
If the HIV person has a high creatinine level, what changes should be done in the medicine?
Yeah, then tenofovir dose adjustment you may have to do, or may have to change the tenofovir to other abacavir or drugs which are more friendly to kidney.
Dr. Janardhana has come out with another doubt. A PLHA co-infected with HBV on TLD with high HBV DNA, can we add in anti-care?
Yeah, the problem there is if patient is on tenofovir and lamivudine, the HBV should be suppressed. So if it's HBV is not suppressed, that means there is some HBV resistance. So HIV may be still sensitive. So they may have to, I'm not an expert in hepatitis part, so they may have to consult the hepatologist or hepatologist and add the drugs which are indicated for drug-resistant HBV. Maybe Indicavir or other drugs. They can have that also along with this.
Dr. Jalipa is asking, sir, when should one plan lumbar puncture in PLHIV? reactive for VDRL or TPHA to rule out neurosyphilis? Is it determined by symptoms or any other criteria?
This is about neurosyphilis.
Neurosyphilis.
Okay.
To rule out neurosyphilis, people living with HIV, when can we plan a lumbar puncture?
Okay, the current CDC guideline doesn't advise NLP. It says if there's no clinical manifestation suggestive of neurosyphilis, you can give 3 doses of benzethine. But if there's any clinical indications suggestive of neurosyphilis, you should do NLP. Otherwise, no need.
Okay. Dr. Renuga has asked, where all do we have RT-PCR bar NAT 4th generation antigen testing?
4th generation ELISA is available in most of the big commercial labs. Now it's available. I don't think it is easily available from the program because we don't have that in the program. But RT-PCR is available in the program whenever necessary for the child, and viral load and PCR is easily available. It's not machine is not available in every place, but they collect the blood, transport to Thrissur in Kerala or a nodal place, and they test and give the results.
Another question from Dr. Bindu is, if we are keeping confidentiality, how can we send interdepartmental consultation?
Yeah, interdepartmental consultation, it's not secret. It is confidentiality. There's a difference between secret and confidentiality. Secret is something which you keep and don't tell anybody. Confidentiality, again, can be 2 types. One is you are keeping it to yourself, and it can be shared confidentiality also. Okay, so for example, one of my patients who was admitted in a medical ward, his data was, positivity was detected by a sweeper there. Sweeper went and told a 3rd person. So I called the sweeper and said, you don't have any business to know the status of this person. But nurse probably has, doctor has. Okay. So if that doctor of the other ward knows it, there's no harm. But he should not disclose it to a another person. So this is something which we should learn.
Okay, sir. Dr. Priya has one question. Sir, is it okay if we write in the prescription that the patient is on ART?
Where do you want to write in the prescription? The prescription is an order to the pharmacist. Pharmacist need not know whether the patient is taking the medicine because he is HIV positive or hepatitis B positive. Okay, both can have same drugs, or he is taking it for PrEP or post-exposure prophylaxis. Okay, so this is an order to the pharmacist. You write, please issue these medicines and how to take it. That's all, and sign it.
Thank you, sir. Maybe the next question would be for Yamini, ma'am. What is the latest infective rate in children and adolescent age group? And what about Kerala's zero HIV goal by 2025? That's by Dr. Renuga, ma'am.
See, we have a total prevalence rate only. We do not have children and adolescent infective rate right now, because in surveillance also only the adult population is taken. But we can compare the percentage of age group wise. We can compare how much of infective population is in this particular age group compared to the other particular age group. That is how we have been able to show that through the years. I think in the last 3 years, it was 9. From 9, it went to 12. And from 12, it went to 14. This 15 to 24 age group. So that is why we are saying that the infectivity in this age group is slowly increasing.
Okay, thank you, ma'am. Dr.
Was there another question too? What was there a second question?
Yeah, there was a second question like, what about Kerala's zero HIV goal by 2025?
So we had a goal which was before the SDG goals of 2030. We wanted to come to a zero transmission by 2025. This was something which we had planned around in 2020. Along with our ACS, our health secretary, who was very much interested in this program. But then COVID happened, and that took our program backwards because nobody could come. Even the screening during that period is very less. Though we used to get 100 new cases per month, at that point of time, the whole year we got around 840 positives in that whole year. So the whole program, the whole health system programs had all gone backwards because of the COVID. And so we could not reach, we are not able to reach by 2025, we are not able to reach the destination of zero transmission right now. And also the dynamics in our society, in our population has also changed now. The dynamics in our society has changed. So actually we are seeing increased infection.
Dr. Praneeth has a question. How about vaccinations? Which one is preferred to give?
I didn't get the question.
I think the question is like this, in HIV, how about giving vaccinations?
Yeah, in children, all the live vaccines are not recommended. Other vaccines can be given. And if there's absolutely normal immunity, probably live vaccines also can be given.
Okay, sir. Dr. Chitra is asking how to break the HIV positive result to a patient. I think sir had explained it very well. Is the partner testing mandatory?
Yes.
Nothing is mandatory.
Nothing is mandatory.
Yeah, if the partner wants to get tested, we can get, she can get or he can get tested.
How to proceed with contact tracing? Any standard procedures?
How to?
Proceed with contact tracing.
HIV, we don't do contact tracing.
Then another question is, Dr. Praneeth, is there any cancer screening suggested at early or later stages of HIV?
CA cervix, this pap smear is recommended every 6 months, even though it's not being done always. It is recommended for every lady beyond an age, for HIV positive ladies also, because there's slight higher chance of getting CA cervix in HIV infected.
Another question is, HIV positive patient on ART, can we determine the infectivity based on CD4 or viral load?
Viral load.
Okay, so thank you, sir.
Because there can be a discordance between CD4 and viral load in some patients, but viral load decides the transmission.
Dr. Gobinath has one question. How often dapsone cross reactivity with cotrimoxazole happens? That is one question. And it's because sir said dapsone can be given. Then in G6PD deficient patient with cotrimoxazole hypersensitivity, what do we prescribe?
Oh, that's a difficult situation. Okay. Pentamidine is probably the solution, but which is not available. So that's a difficult situation. But what kind of sensitivity to Cetran? If it is only a micropapillary rash, anyway, patient with the PCP will be on high dose steroid. That will take care of that. If it is anaphylaxis, you can desensitize and give cotrimoxazole. There is a clear protocol for desensitizing for type 1 hypersensitivity. So what Steven Johnson is tricky.
Then Dr. Sneha is asking HIV positive patient with co-infection of HCV infection. Any drug to be added with TLD for HCV?
HCV.
HCV, hepatitis C virus, sir.
Treat HCV as HCV, treat HIV as HIV.
Okay, sir. Dr. Rajesh has asked, is there any awareness program going on about HIV and STD in adolescent school children?
So, Yamini madam?
Yamini madam.
Yes. There is an adolescent program in our IEC division, which is being done through uh, other agencies. The NSS is helping us, as well as Nehru Yuva Kendra is helping for out of school children. So that kind of awareness is going on. Other than that, we have an adolescent reproductive and sexual health program, which is the life skill education program, in which, even though we will not be specifically talking about HIV and AIDS, we will be talking about safe practices, sexuality. All those things will also be coming. How far that is being done at the school level is another question.
Dr. Hasina is asking, is pre and post counseling done in private labs when HIV is tested?
I don't think so. Most of the places. There are some places which done. Private hospitals, yes, there are private hospitals with full-fledged ART centers, ICTCs and like that. But small labs, I don't think anything is happening. There's one more thing. Initial days, we were insisting on detailed pre-test, post-test counseling for every test. But there is something called opt-out mechanism. Okay, because now the scenario has changed. Earlier days, we used to say that HIV is a deadly disease. You are, if tested positive, difficult. Now we are saying that come get tested.
Yes.
If not tested, you can be in trouble. If you tested positive, your life is saved. So we are saying that exactly the opposite. Okay, so one of the guidelines is to make an testing opt-out mechanism. So we tell everybody that anybody who comes here for these situations, especially in a high prevalent state, we will test. If you don't want to test, tell us. We will not test you. So that also is acceptable in healthcare settings, especially in high prevalence India. So the onus of saying no is with the patient in that situation. Okay. But ultimately, patient should know what is happening. You cannot do it clandestinely without telling the patient and then later say that we tested it and you are positive. That so patient should know what's happening and patient should get a chance to clarify what it means to him and make a decision.
Okay, sir. Dr. Janardana has, I think, answered the previous question for co-infection with HCV. What doctor is saying is sofosbuvir plus daclofenacin or sofosbuvir with velpatasvir for 3 months.
Yeah, that's anti-HCV drugs.
And then refer the patient to the center. Now, Dr. Simi has one question. I think that is the last question in this series. When we do HIV testing before surgical procedures, is it mandatory that pre-test counseling should be done?
Why do you want to test before surgical procedure?
We usually do, sir.
Usually done, sir.
That's a different
Usually
issue.
do.
That's a different issue. Somewhere we failed. But ideally, there is no need to test because anyway, you'll have to, whether positive or not, you'll have to take a universal precaution. Once you take universal precaution, HIV will not transmit. And in case by chance you get poked, you can take pre-exposure, post-exposure prophylaxis. It's almost 100% effective. So the reason for testing is not to take precaution, which will give you hepatitis B. Because, okay. So because you presume that once HIV is negative or hepatitis B is negative, that patient is safe. No. The patient can be in window period, maybe carrying some other virus. Okay. Maybe having Zika virus. He came yesterday from Brazil or some other place. Okay. So you can get all other infections. just because the patient is HIV negative, and very likely to be in window period also.
Thank you, sir. Thank you, Yamini madam. Let me now invite Sri Biju sir for delivering the vote of thanks.
Joan ma'am, there are just 2 more questions left actually. We wanted a break from our session. That is why we put in a few questions from the chat box.
Okay.
There are 2 more questions left, ma'am. Like one is, we're asking sir, Ajit sir, please explain us the confusing World AIDS Day theme of this year. Where is the disruption and what we have to overcome and something.
Can you show the slogan?
I have not got it here now, sir. It's overcoming disruption and transforming AIDS response.
Okay, it's explained. Because always we had problems in AIDS response from day one, which has caused a lot of disruption. Now, in the last few years, we are probably seeing more disruption because less funding, less coordination, which is pushing the epidemic now. So we are realizing that, like Dr. Yamini said, what I said, we are seeing increased infections because there's a disruption in the program, not only state program, all over the world. We started with that. So be careful about that. Go back to the full steam mode. That is the meaning of this year's
And
slogan.
last but one slide for the brilliant academicians in this group. What is latest on HIV updates on drugs?
Yeah, there are
very long-acting drugs.
Latest things like lenacapavir. This is once in 6 month injection, can be used for prophylaxis and as treatment. It's quite costly, but it has become it's becoming available. Another thing, yesterday probably you read in newspapers, stem cell treatment can lead to complete cure. It's all very initial. This thing. These are 2 things which I can remember offhand.
So, what is your key message to all of us on this World AIDS Day celebration?
As doctors, never tell no to anybody. When we all started HIV care, what our message was, there's no disease which doesn't have treatment. Even if you don't have ART, even if you don't have fluconazole or alpha-dressin, you have paracetamol. It will work for headache. Patients come to us because others say no. The others cannot do anything, so we cannot say no. Then once we say yes to them, more people will get tested and more people will get controlled. So the transmission will come down. Once you say no, people will not come to us. So the disease will spread and you also will get infected somehow. So to be safe, say yes. That is one message. And another thing, it's time we should have a relook of what we were doing the last few years. And probably things are going out of control, not only in HIV. HIV, it's okay, we have ART, but other infections also. But we need to change our strategy. The old strategies will not work. Like Madam said, over the last few years, the dynamics completely changed. So we may have to have new strategies to address the changed paradigm. Otherwise, we will not be able to. The old weapons will not work on the new challenge. We may have to have new strategies to address this issue.
So that was a wonderful session, sir. Over to you, ma'am. Joan, ma'am.
Now we'll have the vote of thanks by Sri Biju, sir.
Good evening, all. A very highly insightful webinar on HIV has come to an end. I would like to thank especially two people, Ajit sir and Dr. Yamini madam, for providing a lot of good insights and making this program very academically useful. It did not feel like attending a academic session. It was just felt like a casual talk between experts. That's all. And special thanks to Deepa for bringing back Ajit sir from hibernation. Actually, during my college days or PG days, we were really excited by the dedication showed by Ajit sir, and there was one more person. I think it is Dr. Sajid. I think, as Yamini madam has told, it's really shocking revelation that even young people are getting infected, and the casual sex is becoming more prevalent in both the sex. That's what the statistics show. So it's my proud privilege to render the vote of thanks. So I would like to thank Chairman Rathamani Madam. She's the chair of the Community Dermatology and Media Cell, for her gracious welcome address. And she's also a great leader, both over here in IADVL and IMA. And she has a great interest in this topic. I would like to extend my sincere thanks to Dr. David Pudugarden, who is the president of IADVL Kerala, for the inspiring presidential address. He always comes out with very novel ideas, and this is also one of his ideas. Thank you, Dr. Yamini Madam. She's the Deputy Director of KSACS. I have been hearing her name for a very long time. I am seeing her for the first time. Thank you, Madam. Thanks a lot. I also work in the health department. Thank you. And I would also like to thank Dr. Joanne, who is the State Secretary of IADVL Kerala. She has been planning all this program for a very long time. Thank you, Doctor. So I would also like to thank all our esteemed participants who actively engaged in today's very enriching deliberations. And your thoughtful questions, reflections, and presence in this program. My sincere acknowledgement to every member of IADVL Kerala, KSACS, and our organizing community for their meticulous efforts behind this program. Finally, I thank each one of you who joined us today. I could find a lot of luminaries I could find Anthony sir also, who is an international public health expert. He was also there as a participant. So with these words of gratitude, we would like to formally conclude today's webinar. Thank you all and wish you a pleasant evening. Thank you. Good night.
Thank you very much.
Thank you.
Thank you so
Very
much. Good
Ajit
night.
sir. Thank you very
Okay.
much.
Thank you, Yamini Madam.
Thank you,
you.
Ajit
Bye.
ma'am.
Good night.
Good night.
Yamini
Thank
Good
you.
night to all
Good
my
night.
dear friends.
Good